If everyone would, thank you, Rana. If everyone would please put their name and where you're from in the chat, that would be helpful. Not necessary if you don't want to, but we would appreciate it very much. Tonight we have the one of my favorite people here who is in the advocacy world, Ellen Andrews here. And I will just read a little bit about Ellen.
Oh, God. Here
She
we go.
she is the chair of Connecticut Health Policy Project since 1999 when it began. Um, she has this amazing Twitter feed. If you don't follow it, please do. She does a Connecticut Health Notes blog, and she updates on state health policy. Her experience includes teaching and research. She coordinates a multi-state health policy steering committee for the Council of State Governments Eastern Region Conference and serves on over a dozen state, regional, and local health policymaking councils. She holds a PhD in human genetics from Yale. So many other amazing things, and along with Sheldon, is one of the reasons why we have such an amazing Husky Medicaid system here in Connecticut. So I thank you, Ellen, for being here, and please go right ahead.
Well, thank you. And I really have to work on my bio because some of those things I don't do anymore. So I need to update that. But anyway, so I was going to use some slides. I hope that's okay. All right, I will.
Yes, I think I might have to make you a co-host. But that would be easy. Okay, you should be set.
Sharing. Nope. Oh, yes, I can. Okay. I mean, one participant can share at a time. Share my screen, and now I've got to actually put that up, don't I? You're probably not seeing anything, are you?
Not the slide.
No? Okay. Huh. What am I doing? Wrong. Oh, here we go. There we go. Can you see it now?
Yes.
Okay, good. All right. I've been working on these, you know, how you play with things for way too long. Anyway, so we created a nohuskymcos.org website because the governor, yes, I'm rubbing my temples. The governor has gotten it into his head that he wants to explore bringing the MCOs back to Husky. I heard about it actually in rumors and I didn't believe it. And then I talked to a few other people and other people had heard it and nobody believed it. So I asked the commissioner and she said, yeah, it's true. And it's not clear exactly why, but I will go through. Some of you will remember this. Some of you maybe weren't part of this. God bless you. But it is not something you want to live through again. We had Husky MCOs from 1996 to 2012. We finally got rid of them. We are now saving billions of dollars. People can actually get care. In the first year, we got a third more doctors in the program. We are in the top quadrant of top 25% of quality in Medicaid programs. And so it makes absolutely no sense, but I will go through it. And then if you want to, you can go to nohuskymcos.org at the end and you can sign our petition, which says very simple, Governor, don't do this. And then you can call the governor and we can talk about, and then I leave it to Sheldon because he does this much better than I do. But so that's it. This is, the governor is exploring returning Husky to, where did it go? Why is it gone? Yeah, okay. To managed care. These explorations are happening in private meetings where there is no stakeholder input or legislative input. We believe that sunshine is critical to good policymaking, so we created nohuskymcos.org to inform Connecticut about what's at stake if MCOs come back to Husky. So we're going to talk about what happened before, what the evidence says since then, and how to have your voice heard. Medicaid is Connecticut's state program providing comprehensive coverage. I'm sorry, it's like messing up part of my screen. Oh, there we go. Medicaid is Connecticut's state program providing healthcare coverage to low-income people. I probably should just cruise through these. MCOs are managed care organizations that are hired by a state. These are private insurance company plans. They are very profitable and they run the Medicaid program. MCOs are paid a capitated per person flat fee to cover all the necessary care for their members. It is risk adjusted sometimes in a black box risk adjustment, where if you have higher healthcare needs, they would get paid more for you. So it isn't always true that the most lucrative people to those managed care plans are the healthy ones. If the costs of care are lower than the state's flat fee payments to the plans, the MCO can keep the extra as profit. But if the costs of care are higher, the MCO loses money. MCOs can make money by keeping people healthy so we don't end up in the emergency room or in the hospital, or they can just flat out deny needed care, which is what they did last time. Currently, Connecticut runs our Medicaid program without MCOs. We pay providers directly for the care they give members without middlemen, and we have invested a great deal of money in coordinating care. When we had MCOs, Governor Rowland, God bless him, first hired MCOs to run Connecticut Medicaid in 1996. A state study found that 4 out of 10 providers listed by the MCOs. Now, this was a study, we didn't do it. The state did this, DSS did it. 4 out of the 10 providers they listed did not take MCOs. This is not unique to Connecticut. They're called phantom panels, provider panels, and it's very common in MCOs. Enrollment, and this was not voluntary. You were in, period. It was mandatory. Enrollment in MCOs was regularly suspended because they didn't have enough providers to care for members. An audit commissioned by the comptroller, Nancy Wyman at the time, found that the MCOs were overpaid by millions of dollars. Turns out they undershot that. They were being overpaid by billions of dollars. Connecticut's doctors sued the MCOs for engaging in deceptive, this is a quote, I should put it in quotes, deceptive and improper practices that harmed patients. The state couldn't get data from the MCOs to hold them accountable for the quality of care. So you'd have these lovely contracts, but they were unenforceable. But in 2012, Governor Malloy was elected and ended MCOs and moved to our now successful care coordination model that helps members manage their own care and stay healthy. So, you know, we could be forgiven for going into it in 1996 because there wasn't a lot of evidence about that right then. Since then, there's a lot of, and we're talking independent evidence, not, you know, Lewin or Manat or other consulting studies, but these are studies in peer-reviewed journals. And despite many years and many studies, there is no evidence that Medicaid MCOs improve access to care or the quality of care that members receive. And according to MAPOC, that's according to MAPOC, the Federal Medicaid Oversight Agency. It's also the National Council of State Legislators. I'm forgetting several groups have all looked at all of it and said that it does not improve the quality or access to care. Connecticut Medicaid now without MCOs is among the highest states in the quality of care that members receive. And they don't save money either. Since they're gone, we have saved billions of taxpayer dollars. Connecticut Medicaid's cost control is now the best in the nation. We spend 2.75% of program costs on administration compared to the US average of 8.5, so about a third. Compared to other states, Connecticut spends 7.7% less of our budget on Medicaid. This frees up $4 billion in the state budget for other priorities, things like education and housing and food, higher education. Despite many years and many studies, there is no evidence that Medicaid MCOs save money. The reason it's inefficient. They include things like advertising. There's more than one plan, and so they all advertise to try and get people into their plan. We don't have to do that. You sign up for Medicaid, it's one program, there's no advertising. Federal MCO taxes, the ACA, sorry, taxes private insurance plans. Well, these are private insurance plans. So they have to pay a tax that we have to build in to our premiums. Their MCO administrative costs, I talked about how they're 3 times what we pay. State agency costs to manage those contracts, which we don't know now. Overlapping and duplicate functions between the MCOs with the state, the costs to collect, harmonize, and report data from multiple MCOs. It was when I managed when I staffed the MAPOC, we were always hearing about the fruit orchard, apples and oranges. You couldn't compare this month's data with last month's, and you couldn't compare it with, another MCO. You just never could. 16 years we had it, and they never could give us data that was usable. And this just shows, I put a box around the red, but this comes from DSS's financial trends, the last one we have. We don't have a new one, showing that even though enrollment has all been up, the per member per month costs have been mainly stable, even with the Affordable Care Act enrollment extension. This one, I put the circles in myself, but MCOs will tell you that they are innovative. They can do innovations that, states can't do. Well, this is the Kaiser Family Foundation's list of performance measure focus areas for quality incentives in Medicaid. You'll see that Connecticut is on every line. I should actually look and see if there's any other state that's on every line. Even without MCOs, we're doing all of these things to improve quality. We're also, out of 5 innovations they found in payment, we're doing 4 of them now, and we're going to be doing the 5th one when we have maternity bundles. So when they say we can only do these things with managed care, it's just not true. Let's see. Oh, this is my favorite. John Kramer I spoke with him actually this afternoon. He did a study. When you look through a haystack, you'll eventually find the needle. He did a study looking at early stage cancer diagnoses, and he's an oncologist from Indiana, Wayne State, and also survival out of cancer for cancer in Medicaid programs. And he looked at Connecticut and New Jersey. He started in 2007. We are socio-demographically matched states. And until all of a sudden in 2012, something happened. And New Jersey's early stage diagnosis stayed the same. Ours went up, and it's 4% higher. Our survival rates are 8% higher now. That's people who are alive now because we went for some reason, happened at the same time as we got rid of the MCOs. So this isn't just a discussion about, more convenient health care or the state saving money. This is about people's lives. I'm hoping to get him to do a webinar, actually. So this is a question the governor has asked. Why do most states use MCOs for Medicaid? Number one, it's easier. States with MCOs can outsource a lot of their administration and complaints from the state to the MCOs. And Sheldon can attest, whenever we had a patient with a problem, they'd say, I don't know, call Anthem, call Aetna. It gives more predictable budgets for state budget officers, but there's still a lot of variance. I mean, as when we got more people into Medicaid during the 2008 recession than we did when the ACA expanded Medicaid. So economic issues have a lot more to do with how many people there are in Medicaid. In some states, there are some states where Medicaid is working very badly. So MCOs can actually improve access and quality of care. There's one state I talked to where they had workforce requirements for a short time. And the penalty, if you weren't working enough, was that you would have to go back into fee-for-service. And I remember talking to advocates there, and they said, yeah, that's really bad. I'm like, yeah, that's not true for Connecticut. We actually have we didn't have a great program when they came in, but we do now. And almost all large employers, including Connecticut State Employee Plan, do not use capitated MCOs for cost and quality reasons. So why would we go back when we have 1 million people? The largest, the State Employee Plan has about 200,000 people, I think, in it. So why would we go back to that? What would losing it mean? Husky members would have a lot to lose. The quality of care could sink to the level of most states that have MCOs. Now, without MCOs, we're in the top quarter of states in 17 out of 28 adult quality measures and 13 out of 22 child quality. And that's the top quarter, not just above average. It's going to be harder to get appointments for care, and there will be fewer providers accepting Medicaid at all. There'll be more administrative hurdles to get the care you need. Prior authorization is more common than even in Medicare, which is worse than commercial. That is actually the reason that the author, the oncologist who did that study of New Jersey and Connecticut, that's what motivated him to do it. He was sick and tired of trying to get prior authorization for all of his patients, but only the Medicaid ones. And I said, yep, that's borne out. You're not alone in Indiana. You may not be told about better but more expensive care options, and these problems will fall hardest on seniors, people with disabilities, and communities of color. That would increase health disparities. What would it mean for providers? Long awaited, all those provider payment rate increases. I don't know if you've heard about it. It's been a lot of drama in the Medicaid program, working on figuring out what are fair rates, not just who lobbies the most. That would all be at risk because you'd be negotiating your rates with an HMO. Providers, right, would have to negotiate their payment rates. There'll be more prior authorization, more denials, and delayed payments. Right now, Medicaid pays as fast or faster than most other payers. But when we had MCOs, they waited a year or more. There was always, the claim was never clean, whatever it meant. You'd have the administrative burden of submitting claims to multiple MCOs. And as providers leave the program, there'd be more demand for care would fall on those who stay. Lost opportunities. Right now, Medicaid is working with stakeholders on projects to improve primary care, increase very low provider payment rates, so more will treat Husky members, expand access to mental health and substance abuse care, support justice-involved members to improve their lives. There's a whole list. Connecticut is designing these programs, and right now we can implement them directly, but under MCOs, we'd have to negotiate with the MCOs to implement them, and they would profit from the savings that are generated by the programs. So we'd pay the money, like intensive care management, and they'd get the profits out of it. So Connecticut should not bring MCOs back into Husky. It would lower quality. It costs more. We'll have lost opportunities, fewer providers, more administration, and denied care. I didn't have enough boxes. There are more things I should have put on there. So, well, that didn't take very long. You can go to No Husky MCOs for to keep updated, to get the evidence. We have fact sheets in English. We're getting Spanish. Get answers to your questions. You can join others concerned about MCOs and learn how to make your voice heard. Any thoughts, ideas? Are you still out there?
Yeah, we're still here. If anyone has any questions for Ellen, you can please raise your hand so she can recognize you.
Let's see.
Or I guess you could just kind of yell it out. Oh, Dawn has a question.
Hi, Dawn.
Hi, actually, I have, I guess, a question and maybe a comment. I'll try not to take up too much time. So I'm from Minnesota, and we have the most dreaded MCOs that you were speaking about.
United.
I know exactly what you're talking about. And last year, I'm in two groups, Health Policy Advocates and Healthcare for All Minnesota. Health Policy Advocates is a nonpartisan, kind of a very small group with attorneys, Republicans, some healthcare people, lobbyists, but very diverse. Anyway, we had a bill and we called it Freedom to Choose Bill. And this was our first attempt to deprivatize our public programs. It sailed through until the 11th hour last session, and it was pulled in the conference committee, because of the hospitals. Are you familiar with 340B?
Yep.
Okay, so the 340B and the Hospital Association the lobbyists came strong on the
Mm.
legislators, and they pulled the bill. This year, we tried creative ways because it was still alive, because it was pulled during conference committee. However, we had a so-called public option going through here in Minnesota. It's not really a public option, but it was led by Isaiah, which is a very, very strong grassroots organization, a lot of power. And so no one would hear our bill at all. My question is, and I love your stats. I mean, can you send me your slides?
They're actually on nohuskymcos.org. You can download them.
Okay, I have that. I'll be sharing this with ours. Do you have any suggestions? And maybe we can talk about this offline, because we're trying to get more endorsements, and we're not going to let this go.
Good.
We need to
Good.
deprivatize, and your data shows that it pays off.
Yeah. It's people's lives.
Exactly. Your governor, what party is your governor?
He's a Democrat.
Okay. Okay. No, that's good. So is ours, but he's not very educated in healthcare, but thank you very much. I'm really interested. I'll shut up.
Sure. I forgot to ask if Sheldon wanted to say anything. Sheldon, I'm sure you have lots to add in.
I'll try to be very brief. Thank you, Ellen. I've been trying to get a hold of somebody in Minnesota to get rid of the MCOs because I heard about what's happening there and I didn't know who to call. So glad you're on the call here. Besides the reasons Ellen mentioned why there's MCOs, those are sort of like the practical things, but there's the real world things. Money, lobbying, buying nonprofits. Basically, when we had MCOs, there were many, no, I should say many, there were several advocacy organizations, nonprofit advocacy organizations, who effectively were defending that system because they got a lot of money from the MCOs.
Mm.
And then there's this thing called campaign contributions. I know that in our state, we have a little better control on that, but that happens a lot. And then there's advertising, and that includes jobs. There's all kinds of things that they do once they're there. And that's why, as Ellen said, they're here for 16 years. I think we ran the campaign for 12 years, 10 years intensively. And it was so hard to get rid of them because they were perpetrating, this term has different meaning these days, but what I called the big lie that we do it better and cheaper. And we coordinate care the way you can't do in fee for service, which, as Ellen pointed out, isn't true. None of that was true. And it turned out it was more expensive than not having them at all. But because of that lobbying effort, it made it really difficult. So I'm sorry for people in Minnesota who already have them. But in Connecticut, we have the opportunity to push back and stop it in its tracks. So we won't then have this multi-year difficult effort to get rid of them.
Yeah. Yeah. Once they're in, it is extremely difficult to get rid of them. Yeah, Dawn, yeah. We should send you chocolate. That's what we should do.
Yeah, our fiscal note showed that it would likely save millions of dollars. And like I said, it sailed right through. We've also tried for years, probably 12 years, to get an audit because, like you said, there's no data that shows that this works. And they they refer to an MCO as coordinated care. It has nothing to do with coordinated care, but even the professional, not physicians usually, but legislators mostly, or some supervisors of agencies, say they like them because of the coordinated care. And I worked in healthcare too, so I know how it's nothing to do with coordinated care. But
No.
all right, well, I put my email address in there, so Sheldon, give me a buzz. I'm sure that we'll be chatting later, and we can use all the help we can get. But we're not going away, so.
Yeah, if you go to more evidence, that's where the lit reviews are now on cost and quality. I'm gonna be doing a couple of others like why MCOs, why do 45 states have MCOs? Because that's a question the governor has. It's not irrational.
Yeah,
It's a good question to ask, and we have
Yeah.
answers for that. And I'm gonna be putting that in, and also I need to do a deeper dive into how well Connecticut is doing. And it's embarrassing because we did this, and we won, and then you just kind of breathe a sigh of relief and you never think you could ever go back. And so we didn't memorialize this stuff, and we should have. So I should have done this website a long time ago. So it will be continuing to be updated even after we win and the governor finds his mind again.
thank you.
This is being recorded, isn't it? Ellen, shut up.
That's okay. Rana could edit it. She's good at that, I believe, or her husband can do it.
Well,
I
nobody
could
said
if
we
you
were
really
governor.
want to, but we can
We
make
don't
it
have to.
feel live.
It's fine.
I
It's
said words.
fine. So Ellen, it's www.nohuskymcos.org.
Yep, or .com, either one.
Okay, great. So we can go for this and start calling the governor and start, the fact sheets are there, and we
Yep.
can do this and we can start.
Yep.
Okay, all right, cool.
I mean, we should talk, Sheldon may want to say something about that, because I think there's been talk about call-in days and stuff, so
Okay,
maybe we should be coordinated, but that's Sheldon does that stuff, not me.
okay, go ahead, Sheldon.
Well, I didn't want to comment about that because we're gonna have a meeting of a few advocates and figure out what strategy is. I have no idea what strategy is, frankly. But I did want to point out an analogy that some of you are very familiar with, and that is Medicare Advantage. It really is analogous. So basically, we've had this very efficient Medicare program that has about a 3% administrative cost and has worked pretty well, relatively little prior auth in the traditional Medicare sphere. And you get to go to any doctor you want, right? And overall, it's well run. They do use non-risk insurance companies for certain aspects, for certain processing. Along came the industry, and by the way, you'll be surprised to hear it's the same companies as in Medicaid managed care, mostly. And they said, we can make money in this. And unfortunately, the Clinton administration encouraged that. They called it Medicare Part C. And the Clintons were very, what can I say, corporate, corporatists. And they believed in that as a way of delivering healthcare. I have no idea why. But the result is that now I think it's slightly over half of all people on Medicare are now in these plans. And
Yeah.
guess what happens once they're in them? If they're healthy, it's great. And plus you get like some freebies, you get $1,000 for dental or whatever that you don't have in traditional Medicare. But should you, God forbid, get sick, that's when you find that not all the doctors are there and that there's all this prior auth. And by the way, it's really expensive. Many studies have been done recently showing that it's more expensive than just providing it directly. And when you provide it directly, you don't take off that huge amount off the top for administrative costs and profits. Ellen used the figure 8.5% for the administrative costs overall in Medicaid. I don't think that's fair. I think that's, I know it's the figure DSS uses. I think it's a lot higher because MCOs are like insurance companies. We all know that under the ACA, for example, it's 15 or 20%, right? Take that for administrative costs. It's high. So that'd be great if it was 8.5%. I think it's a lot worse than that. But in any event, in Connecticut under Medicaid, run by us, it's only 2.75%, or in Medicare, it's about the same, traditional Medicare. And so there you see the exact analogy. And as we go forward in this fight, I think we may be sort of pulling on that, drawing on that analogy to help educate people. That's
Yeah,
all.
and the thing about Medicare Advantage is it's not only more expensive for people if you get sick, but it's more expensive for the government too, for taxpayers. It's just, there's no winners here. I mean, I guess unless you're a stockholder.
Well, I will definitely make sure that once we have a few of these meetings, or I think I'm invited to the meeting, I'm not sure. You know, I personally would start calling, because I think any little bit will help, because if we start and it's even staggered and then we do a huge call-in event, that will be even bigger of a impact, in my opinion. But I don't know. I think if we do staggered, if each of us do it and do an action, and then we do another big event where it's simultaneous, where everybody calls, I think it will be a good thing. So I think we should do it. I think if you guys see the fact sheets on the website, and just do it. I'm going to do it. This is so dangerous for so many people. It's just ludicrous. Cut it out now. You screwed us over last session, this session, when you hurt people with disabilities. Now you're going to do it even worse? Come on, man. Really? I can't. And I'm tired of being nice about it too. I keep saying this, but I don't care. But seriously, enough. So I think if everybody's willing to take some action and call the governor's office, and just even staggered, like I said, who can call this one, that would be great.
And the numbers
So
on nomcos.org, and also the link if you want to send an email. Yeah.
great.
Yeah. And I mean, I'm talking to somebody from the office tomorrow, and I'm not waiting for everybody else. I mean, he's going to get an earful.
Good. Good.
I should say that the commissioner has been, I mean, she works for the governor and she's not said anything, obviously, and their staff, but has been very transparent in talking with me, at least. And we have regular conversations, and she welcomes, sometimes I give her an earful. And I mean, in the MAPOC meeting, yeah, it felt like I should apologize. And she said, no, don't. That's what we need to hear. So she's being really great. I also should tell you, and I believe them, the insurers wanted me to tell everybody that this wasn't their idea. The governor came to them. They, their lobbyist was quick to say, this may be an opportunity, a business opportunity, and they answer to stockholders. They don't answer to taxpayers. So they might, apply for this, but respond to the RFI, I guess, is going to come out. But this didn't start with them. I would have loved it to be that, because I would love to rip somebody's throat out, but this started with the governor. It was his thing. So I think that to some extent is a good thing. If we don't, I mean, going up against the insurance industry took us 12 years to get around, Sheldon. So this is just one guy who's still considering it. He has a lot of questions.
Sheldon, I can see you're thinking. What are you thinking? Do I want to know?
Yeah, really, Holly. That's a
I know that's what I'm afraid, but please.
The problem is being recorded. That's the problem for me in answering that question. Let me put it this way. I believe that within the governor's family, there's a general philosophical view that making money in healthcare is a good thing. That's the way that healthcare should be done, is through for-profit entities, which will make a lot of money, but of course they'll do good in the process. So I think there's that orientation. And that's far more important than, as you know, Dawn asked the question about, is your governor Republican or Democrat? I don't know. The Clintons are responsible for Medicare Part C. So I don't know that that's significant so much as these other orientations.
Yeah.
Don
Go
had
ahead,
a
Dawn, you have
question.
a question? Sorry, Ellen.
Sheldon may have answered it, but I was just curious if you have any idea why he would. I mean, it seems like you would think someone's planted this seed. I mean, has he discussed this before?
He has actually,
Not
when he
publicly?
ran, not this last time, but the time before when he was new, he went to the Hartford Courant editorial board and he said, we got to save money. And so they asked him how, and one of his ideas was managed care for Medicaid. And we were lucky. Carolyn Lumsden was there. She's just really, really smart and had been, you know, I'd been haranguing her for years about how awful the Husky MZOs were and how much better it is now. And so she made sure that she's got him in the recording, and she said, yes, you need to do this. And she said, wouldn't you like to write a letter about this, like right now, Ellen? And I said, sure, of course I would. What he said was he had, when he had in the 80s, a cable company for various college campuses. He moved his employees into managed care, and it was a great thing. That was the reason he gave at the time. I'm sure he has, and he talks to other governors right now, and I'm sure they're saying, you know, we love our managed care plans. And for some of those states, it's a good thing. You know, if you're in one of those, you know, states where Medicaid is really, really awful, then maybe it's not as bad. But yeah, here it's a different story, and we just need to get that message to the governor.
So Ellen, in those states, are you talking about the ones that don't have the expansions like we do?
They don't have expansion. They don't have many providers. They pay I mean, I know we don't pay enough, but there are places where it's really, really bad. I mean, we did keep the higher primary care rates from the Affordable Care Act. We're doing better on a lot of stuff, even, you know, I know it's not perfect. It's not even close to perfect, which is why there are like 85 working groups working on things. But that's a point. We have 85 working groups working on stuff. And you know, when things get better, the state saves all that money so that we can spend it, you know, that's part of that $4 billion we get to spend on, you know, other things that we should be spending it on. So it's, you know, it's not perfect, but, and so when he talks to other governors, and part of it is it's a lot easier. It is more predictable. The bond rating agencies like that. They like predictability, even if it's more expensive. And it, you know, it fits within certain philosophies, like Sheldon was saying, that, you know, government just shouldn't be in the business of providing healthcare. I hear nobody disagreeing with me. This is weird. Really, like so different than my students. They just would give me such a hard time for no reason, but because they like to.
I'm a mental health provider and I take Husky, and I'm also licensed in New York. And they do have a you know, what I call kind of a fragmented system of different you know, privatized plans. And it is so much easier dealing with Husky than it is billing in New York State. So yeah, I will make calls. I will encourage people to make calls. I'll do whatever I can, because this would be like,
You know,
this
you have
would
a
make
great
my job
perspective.
more difficult.
That's a great perspective. Would you like be willing to like write an op-ed or something? I'd love to work with
Sure.
you on it. That'd
Yeah, I'd be happy to. Yeah, I'd be happy to.
awesome. Because I mean,
Yeah,
it's, you know, it's
be in
nice
touch.
for me to say that, but I'm not on Husky. I'm not, you know, I don't, you know, I'm not a provider. You
Yeah.
know, I
For
think
for
for you
whatever
to-
it's worth, I'm about to be featured in a ProPublica article
Awesome.
about how insurance companies rip off, well, don't pay the providers.
Mhm.
And that's based on my experience with a couple of, but primarily one particular privatized Medicaid plan called Health First in New York, who just, it was a nightmare. It was just a total nightmare dealing with them. So yeah. So I've had the experience dealing with Husky. I've had the experience dealing with the privatized system in New York, and yeah, Husky is far, far preferable. And yes, I'd be happy to write an op-ed. I'd be happy to have meetings or do whatever.
Great.
So yeah,
Well,
I'd be
maybe
happy.
Holly can
Let me
connect
let
us
me
by
drop my,
email so we can talk. Yeah, that'll be
yeah,
great.
I'll put my email in the,
Okay.
That would be really helpful. I
Yeah.
remember that when we worked with providers extensively in the years to get rid of them, there was kind of a joke that they have three tools relative to the providers. Make prior authorization really burdensome and frequent so they won't even ask. If
yeah.
they ask, deny them. If you deny them and they fight you and you have to and they appeal and you lose, just don't pay the bill, like a certain form of
Oh,
precedent.
yeah.
Just don't pay the bill.
Yeah.
And
Yeah. That
and
totally
so
happens.
they would use those were the three
You just don't
tactics they
pay.
would use basically throughout.
Yeah.
Or make more money and make you not fight with them because it's going to be not worth it for you.
That's exactly it. That's exactly, after a while, you just give up because it's like, especially if you're an independent person like me, you don't have a staff, you're doing everything yourself. Like you just can't do it after a while. So yeah, that's it. They wear you down.
Thank you. I am even more glad that I came on tonight.
Well, I'm wondering what we can do as a follow-up as our group. Within the next 24 hours, we'll have this video posted. We probably won't edit it, but I don't think the spies are going to watch it.
I don't think
If
that
they
the
do,
governor's office would be surprised by anything I said it today.
but I think at that time, once it's posted, we can follow up with an email that has the link to the program, a link to the nohuskymcos.org website, and maybe should we include an Action Network petition that people can sign onto or ask people to call in? I'm not sure, but it seems like we can reach out to our base and also other groups that we collaborate with to get the word out as quickly as we can.
That'd be great. I don't know that there's a huge rush. I don't know that it has to happen if somebody can't do it within 24 hours, this isn't like, at the end of the session, it's at midnight, they're going to make a decision. I think this is happening more slowly, but again, it's happening all behind closed doors. We don't know. I mean, this was, I heard it in rumors. It was a big secret. And I called a reporter and said, you need to look into this because I think it's true. And that otherwise it still would be happening and we would never know until the RFI comes out. It's really disturbing. And I have argued that the RFI needs to be made public. I don't know if everybody knows an RFI is a request for information, but it often leads to an RFP, which leads to a contract. And so the way that's structured often is how the program gets structured going forward. And they're doing that all behind closed doors. And typically these things, certainly RFPs are not shared because you don't want one bidder to know what somebody else is paying, but I am asking for the RFI to be public because an RFI, they can promise, the moon, the sun, moon, and stars. And, the governor and others might look at that and say, oh, wow, they say they can save us, billions of dollars. But it's not enforceable. That's not the contract. That's just it's more marketing than anything else. So we'll see when that comes out, but there's just been too much secrecy around this all along. And it's funny because, so many other things they do, this administration is much more like throw out trial balloons and see how it happens. But this one they held really close. I think they knew it was kind of incendiary. I think Don has something in, but you're.
Yeah, I just wanted to say, another thing that we have done, we had worked on transparency and trying to get an audit because we were trying to show, or at least bring it to daylight, if it is doing better, if it is, less saving money. But we found that you can't, and you may have found the same thing. And we hired a company, and we actually met with our legislative law auditor at the state level, and we found that there's a clause built into their contracts. It's a proprietary clause, so it's trade secret, and that clause prevents them from showing the data. So legally, they don't have to. I mean, we will never get that. And right now, we were really, really pushing for this because their contracts are due, they terminate in 2026. So we thought, perfect timing, but it didn't work. So I don't know.
Yeah,
Maybe they just won't renew their contracts, but
yeah, the comptroller, there's a link in, I think it's the talking points on the more evidence page to the audit that the comptroller's office did at the time. They hired, I think it was Milliman to be able to do it, and they can get access to those things that we can't get because you're right, it's not public, but they can look under the hood and they promise to keep it quiet, and apparently they're trusted to do that. But you have to hire somebody really expensive to do it.
I think this is the time to just mention that the long saga that we never wrote up is the problem, because we didn't write it up, included litigation about the issue of being subject to the Freedom of Information Act, whether the MCOs are subject to the Freedom of Information Act. We actually won that. We won that they, in fact, are subject to the FOIA, but that's because of the nuances of Connecticut state law, and most state FOIA statutes or sunshine laws, whatever they're called, do not have that. However, there is another strategy, and which we use, which is that you can, as a matter of public interest, put political pressure on your agency to request the data from the MCOs, regardless of what their contract says. And it's a matter of political pressure I'm talking about. Embarrassment, media, that's what we used extensively, to the point where they feel the state has to ask for it. Now you create a conflict, which is hopeful, because now the MCO doesn't want to be accountable to the taxpayers. That was our headlines. MCO, big, huge state contractors being paid hundreds of millions of dollars, don't want to be accountable to the taxpayers paying them. And we got a ruling from our attorney general, and I suspect that Minnesota's law is the same, because they're pretty carbon copy, except for the big thing I mentioned. And the proprietary thing is actually discretionary for the state. So in other words, yes, there is an exception to the duty to produce to the public when they ask for it under FOIA, anything that might be proprietary. But what Blumenthal, then the Attorney General, explained to DSS is that's a choice. You don't have to honor that. You could withhold it from the public, but you don't have to. And once you get there, then it's hopeless politically to withhold it. So there are ways to get around even the fact that your statute may not be as good as ours. But we can talk offline.
Yeah, the way that happened in the press was there was a Yale professor who was working with students around the fact that nobody could get any care and healthcare in Husky. And they asked doctors, why don't you take it? And doctors said, I don't get paid enough. And how much do you get paid? Well, I can't tell you how much I get paid because it's proprietary. So they went to DSS and asked, actually the reporters went to DSS and said, well, how much do they get paid? And DSS said, we don't know. We don't care. I was like, what? You give them all this money and you don't even know how much they're paying them? So get a reporter to ask that question of the department to say, yeah, we don't know. We have no idea. We don't care. As long as people are getting care, those wonderful apples and oranges we heard about, but they're data fantasies. I really have to, I'm getting tired. I'm saying things I shouldn't say on a recording. It's just, I also, when this happened, it was weeks before I even talked to Sheldon probably about it, and just said, there's this rumor I've heard, mostly because I just couldn't believe that this was going to happen again. It's really hard to think that we could go back there. It's scary. It's emotionally hard to do, to even come around to think about.
We're gonna win it. We're gonna win it. We're gonna need your help. But I don't think there's any question in the end, if we put our mind to it, that we're gonna win it.
You said that last time, and it was true, but it was 12 years, Sean.
12 years.
Well, I think it's true too. The trouble is that the effort it takes to fight this does distract us from some other things that we should
Yes.
be doing that are really steps forward and not just preventing the steps backwards. So for me, that's the frustration.
And I agree with that totally.
Well, it's like 4 minutes till 3 minutes or till 8 o'clock. Does anyone have any last questions? I think we've committed to doing a follow-up email when the video is posted with the website information so that there can be some follow-up. And I'm thinking we'll coordinate with some of the other organizations that, we talk to. So,
And I'll be calling Donna, and she'll be writing an op-ed. Very cool.
yeah, that sounds great. And there might be other people, who in the state who are medical providers. I'm thinking of some of the physicians I've met who are in PNHP who would like to stay on the national care front, but also keep getting dragged into what's happening more locally.
Yeah. Yep. Lots of voices.
Well, thank you, Ellen, and thank you, Sheldon. I'm going to shut off recording.